Good afternoon. Our lecture for this afternoon would be on abortion and ectopic pregnancy. Outline of this discussion would be definition, pathogenesis, risk factors, incidence, management, and complications of abortion and ectopic pregnancy. Our reference would be Williams' 25th edition, chapter 18 and 19. Abortion is defined as the spontaneous or induced termination of pregnancy before fetal viability. This is pregnancy loss before 20 weeks age of gestation and fetal weight of less than 500 grams. So we could hear terms such as spontaneous abortion, recurrent abortion, habitual abortion, preclinical abortion, embryonic abortion, early, missed, late, and threatened abortion. Spectrum of which is as follows. Threatened is pregnancy with viability, presence of vaginal bleeding, cervix is closed. Recurrent and habitual would depend on frequency of abortion. Preclinical and embryonic would depend on time of diagnosis, and early, missed, and late would depend on age of gestation. So we shy away from the term abortion because of its negative connotation, and we recommend the use of miscarriage. So threatened abortion is ideally called threatened miscarriage. Spontaneous abortion would be spontaneous miscarriage. Recurrent abortion and habitual abortion would be recurrent miscarriage. Embryonic death would be fetal loss. Early, missed, and late abortion would be pregnancy loss. So spontaneous miscarriage would be an embryonic, which would mean that there are no identifiable embryonic elements, or this is what you call blighted ovum. Embryonic would be the ones that contain fetal parts, often with developmental abnormalities. Incidence of which would be at 11 to 22%, and this usually be 5 to 20 weeks. Two-thirds of these abortions would occur in early pregnancy and would be clinically silent. For fetal factors, 50% would be normal karyotype, but 50% would have abnormal karyotype. Of this 50%, 75% would occur in the first trimester, particularly within 8 weeks. 95% would be maternal gametogenesis errors, which would highly depend on maternal age. 5% would be paternal gametogenesis errors, most common defects of which would be your trisomy 50 to 60%, monosomy X, this is associated with your Turner syndrome 9 to 13%, triploidy would be your 11 to 12%. So in general, miscarriage that is spontaneous occurs without medical or mechanical means to empty the uterus. Exact mechanisms are not always apparent, and in early abortions, spontaneous expulsions are nearly always preceded by death of the embryo or fetus. So your hemorrhage occurs in your decidua basalis, and your necrotic tissue forms around that bleeding, eventually making your gestational sac detached. And this would eventually lead to bleeding and expulsion of products of your conception. For maternal factors, these are usually the euploid abortions that would primarily be due to maternal factors such as age. So these are the following: causes of maternal factors, your infection, maternal disorders, cancer, surgical procedures, nutrition, socioeconomic factors, and environmental factors. This is elucidated in the following table. So, common sources of infection for abortion would be your herpes simplex virus, HIV, Treponema pallidum, and group B strep. Hence, we do screen for these infections. Anatomic, so structural, such as your septate uterus, or if it's acquired, your Asherman's. Endocrine, most commonly any diabetic or thyroid dysfunction. Immunologic, your chronic medical conditions, and social factors such as smoking, caffeine, and environmental factors such as the following. For paternal factors, what was listed was increased. So this would be your classification of abortion. Threatened versus missed. Threatened, you have your closed cervix, uterus enlarged to age of gestation with fetal heart tones. The only difference with missed is that your missed abortion would have absent fetal heart tones. And then you have your incomplete and complete abortion. Your incomplete, you have your cervix open with passage of material already coming out. Your complete, all remnants have been evacuated, so your cervix is already closed, and your uterus is not compatible with age of gestation. And then you have your inevitable, you have your ruptured bag of water, cervix may be open or closed. Uterus may or may not be compatible to age of gestation. So as mentioned in the previous slide, threatened abortion would have your vaginal bleeding, a closed cervix with less than 20 weeks. So even if the fetus survives the threatened abortion, adverse outcomes during pregnancy would be previa, abruptio, manual removal of placenta, and an eventual cesarean section. For fetal, you may have preterm rupture of membranes, preterm birth, low birth weight, fetal growth restriction, and fetal death. For missed abortion, there's discharge but closed cervix with absent fetal heart tones in a pregnancy less than 20 weeks. Incomplete abortion, there's bloody discharge with passage of meter material, cervix is open with placental tissue per os. Complete, there's passage of meaty material with bloody discharge. Since the remnants have already been evacuated, your cervix is closed. Inevitable abortion, there's bloody discharge with ruptured bag of water. Your cervix may be open or closed, and uterus may be enlarged or not according to age of gestation. Septic abortion is that where there is presence of infection. Usually these are induced abortions with history of abortifacient intake. So in summary, this would be your classification of your abortion, how they are described and how they are managed. So this is your threatened, inevitable, incomplete, and complete, missed abortion. So guidelines for your early pregnancy loss would be your sonographic findings. So usually a crown rump length of greater than or equal to 7 millimeters, but still with no heartbeat, points to early pregnancy loss. Or an MST, or that is your mean sac diameter, of greater than or 25 millimeters with no embryo. Furthermore, an initial ultrasound scan with a gestational sac but with a yolk sac and more than 11 days with no embryo with a heartbeat is seen, or a gestational sac without yolk sac and more than 2 weeks no embryo with a heartbeat is seen, you could diagnose early pregnancy loss. Other indicators that we use would be fetal bradycardia. So anything less than 110, you suspect higher risk for pregnancy loss, and subchorionic hemorrhage. For recurrent miscarriage, it is defined as 2 or more consecutive pregnancy losses confirmed by sonographic and histopathologic examination. Usual causes would be genetic. These are your chromosomal abnormalities. Anatomic, your structural defects. Immunologic, APAS. Endocrine would be thyroid and your diabetic disorders. If it's mid-trimester, these would be frequently chromosomal aneuploidies or due to cervical incompetence. If your cervix is incompetent, you may do prophylactic cerclage, contraindications of which would be bleeding, contractions, and ruptured membranes. Cerclage sutures are usually removed at 37 weeks to allow for spontaneous labor. Induced abortion, although not legal in the Philippines, there's therapeutic with medical indications, or elective. Elective would be elective without medical indications. So we could manage it medically with medicine such as your methyl ergometrin maleate, surgical, dilatation and curettage or vacuum aspiration, and expectant spontaneous expulsion of fetus. This would usually be based on the results of your ultrasound if there are a big number of retained products in your uterus, or it would depend on your age of gestation. Usually, we do not curette outright abortions which are late because 12 weeks bones have developed and may predispose one to uterine rupture because of bone perforation. As mentioned, complications would be uterine rupture and uterine synechia, which leads to Asherman syndrome. This is your overzealous curette of your endometrial lining leading to uterine scars. So for ectopic pregnancy, is an abnormal pregnancy implantation in sites other than within the endometrial lining of the uterine cavity. So this would be improper implantation of your blastocyst. So this is 0.5 to 1.5% of all first trimester pregnancies. But it's responsible for 3% of pregnancy-related deaths. Hence, the importance of being able to recognize at the onset ectopic pregnancy. So 95% would occur in the fallopian tube, 70% of which would occur in the ambula, and the rest would be at your isthmus, fimbriae, or your insertion. The other 5% would be your abdominal, cervical, cesarean scar, but most would be a tubal pregnancy. So compared to your normal pregnancy, your ectopic pregnancy occurs by your egg releasing from the ovary and traveling down the fallopian tube. More often, this fallopian tube is blocked and the egg implants in the fallopian tube, thereby having an ectopic pregnancy. So what happens? Your fertilized ovum travels through the fallopian tube, and then the zygote comes to lie in your muscular wall. Then it rapidly proliferates, trophoblast erodes the subjacent muscularis, and opens the maternal blood vessels, thereby leading to hemorrhage. Risk factors would be tubal factors such as a previous tubal surgery, previous ectopic, inflammatory disease factors, artificial therapy, and contraceptives. So it is classified into high, moderate, and slight risk. So high risk would usually involve prior surgery, tubal sterilization, previous ectopic, DES exposure, having an IUD, and a documented tubal pathology. Moderate risk would be infertility, multiple partners, genital infection. and your slight risk would be a previous abdominal surgery, smoking, douching, and intercourse less than 18 years of age. It could be further subdivided into two. So factors that prevent or retard passages of the fertilized ovum into the uterine cavity, or factors that influence tubular function that delays passage into the uterine cavity. So your tubal factors would be usually affecting the passage, so that would be your prior surgery, salpingitis, and the like. Factors that affect tubal function would be changes in estrogen and progesterone, use of progestin contraceptives, use of IUD, cigarette smoking, and douching. Okay? So the classic triad of your ectopic pregnancy would be amenorrhea, abdominal pain, and vaginal bleeding. So if we will go back to our lecture in your abortion, it would present the same way. So it is an important differential of the other. For diagnosis, we use beta HCG. With for urine, it's 20 to 25 milli-international units per ml. For serum, it's less than 5 milli-international units per ml. There is a discriminatory level depending on the institution. Usually, it's 1,500 milli-international units per ml to diagnose ectopic pregnancy. So for transvaginal ultrasound, we usually look for a trilaminar endometrial pattern and an adnexal mass which is separate from the ovary. Serum progesterone is rarely used, but it is usually, if it's more than 25 nanograms per ml, it excludes ectopic pregnancy. The presence of hemoperitoneum in ultrasound and cholecystectomy also points to a diagnosis of an ectopic pregnancy. Endometrial sampling and diagnostic laparoscopy is also used. So this is an example of an ultrasound. So a detection of a complex or cystic adnexal mass. So this is your Bagel sign. So visualization of an embryo, fetal pole in the adnexa, and of course the absence of an intrauterine gestational sac when your level is more than 1,500 milli-international units per ml. This is an example of your laparoscopic procedure. For surgery, this is ideal compared to the open when it comes to ectopic pregnancy. So that is your fetus, and that is your ectopic pregnancy. So timely intervention, you would save the mother from rupture and deadly hemorrhage. Of course, sequela would be long-term infertility, rupture that may lead to surgery, and we do not want that. Okay, so we could either do medical management through methotrexate, which is a folic acid antagonist. To counteract methotrexate toxicity, we give leucovorin, which is its natural competitor. For surgical, we do salpingostomy, that is healing with second intention, complication of which would be a persistent trophoblast, which is treated by methotrexate, or full or partial removal of your fallopian tube, which is a salpingectomy. So there are other management for your other ectopic pregnancies: corneal resection, cesarean scar, cervical, abdominal, ovarian pregnancy. Nice to know at your level, but suffice it to say there are certain criteria that would point to these kinds of ectopic pregnancy. So for between medical and surgical, criteria would be: for medical, patient should be hemodynamically stable. Age of gestation should be less than 6 weeks. tubal mass should be less than 3.5, beta HCG should be less than 15,000, no fetal heartbeat. For surgical, if the following criteria isn't met, we go for surgical. Laparoscopy is the procedure of choice for ruptured ectopic pregnancy, as well as when medical therapy is contraindicated. So we monitor for methotrexate toxicity and we counteract that with leucovorin. So baseline and serial treatment, post-treatment of serum beta HCG needs to be measured. If lab is not available, we undergo exploratory laparotomy, thereby salpingostomy and ursalpingectomy. Methotrexate management could be single or multi-dose. So this is for self-assessment. Please answer. Match the diagnosis with the clinical features. And identify the location of the ectopic pregnancy. Please forward your answers to my chat box in our MS Teams. Thank you for listening to this OBGYN lecture. Please subscribe to my channel for more lectures on obstetrics and gynecology.